1, 2,
And review, female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
Let's start
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the echo people say? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
So, what if I told you that a broken heart isn't just, a metaphor?
Right. It's actually a massive physiological event.
Exactly. Like that profound grief isn't just an emotion. It's a biological crisis that can literally alter your adrenocortical activity and spike your growth hormones.
Oh, it absolutely crashes your immune system. It can keep going until your body just, gives out.
Yeah, and normally when we talk about a medical diagnosis on this deep dive, there's this expectation of precision, right? Like engineering.
Like a broken arm. The X-ray shows that jagged white line, and the doctor just points to it and says, there it is.
Right. It's binary, it's clean.
And as clinicians, we really find comfort in that. We like things to be visible and neatly categorized.
So we could just, administer the exact right protocol and move on to the next room.
Exactly. But then you step into the world of human emotion.
The medicine stuff.
Yeah, the neurodevelopment, the profound loss, and suddenly that X-ray machine is just completely useless.
We're looking at a diagnostic landscape that is entirely invisible to a CT scan. But it can be just as lethal as a ruptured appendix.
It really is the absolute definition of diagnostic muddy waters. You are dealing with the human psyche actively trying to survive a psychological amputation.
Wow, psychological amputation. That's a heavy way to put it.
But that is exactly where we're operating today.
Which brings us to today's mission. Welcome to the deep dive, everyone. Today, we have a very specific, highly specialized goal.
We are stepping into the role of elite psychiatric nursing educators.
Yes, and our mission is to mentor you, the listener, through the definitive clinical realities of navigating the dimensions of loss and the grieving process.
And we know exactly why you're here listening to this. You are looking for the fastest, most effective way to master clinical judgment.
Right, you want to ensure safe patient care. You don't want, academic fluff or abstract philosophy.
No, you want to understand what is actually happening in your patient's mind and body.
So you can intervene effectively, pass your boards, and actually save lives on the floor.
Exactly.
Okay, so let's unpack this. The core philosophy we are dealing with today presents a pretty massive paradox, doesn't it?
It really does. On one hand, loss is the fundamental catalyst that allows a person to change, to develop resilience, and to fulfill their innate human potential.
But in the exact same breath,
it can be utterly devastating. It can be a full-blown psychiatric emergency.
So how do we turn this dense psychological reality into practical, life-saving nursing knowledge?
Well, we do it by applying the 80-20 rule. As your mentors today, we're going to strip away the noise.
I love that. Give us the core stuff.
We're focusing on the vital 20% of the clinical concepts that will yield 80% of your understanding.
So this is the high-yield overview.
Exactly. This is the material that will carry you through NCLEX-style questions and, infinitely more importantly, through the reality of a 3 a.m. shift on a med-surg floor when your patient is just completely inconsolable.
All right, let's get right into that 20% that matters most. The absolute must-knows. Set the baseline for us.
The first must-know is differentiating between the types of grieving conditions. You have to be able to instantly, reflexively distinguish between three things.
Okay, what's the first one?
First is normal grieving, which is simply the psychological and physiological process of experiencing grief.
Which is the baseline human reaction.
Right. Second is disenfranchised grief. Now, this is loss that is unacknowledged, hidden, or actively stigmatized by society.
And the third?
Third is complicated grieving. This one is prolonged, it's dangerous, and it's maladaptive.
So if you cannot tell the difference between these three states, you basically can't formulate a care plan.
You're flying completely blind.
And when we talk about formulating that care plan, we absolutely have to talk about the must-know safety risks. Because as nurses, safety is always, always the top of the hierarchy.
Always.
What is the absolute highest priority here?
The red flag that should immediately stop you in your tracks is recognizing suicidal ideation during complicated grieving. That is priority number one.
But it's not just the obvious threats of self-harm, is it?
No, not at all. You must also monitor for severe physiological neglect.
Like what? What does that look like?
We're talking about the patient's failure to eat, failure to sleep, or failure to perform basic activities of daily living, ADLs.
So if the grief is literally starving the patient,
Or dehydrating them into an acute kidney injury, yes. That is a psychiatric and physiological emergency requiring immediate intervention.
which naturally leads us to the must-know communication strategies to handle those emergencies.
Right. We'll dive deep into techniques like open-ended questioning and reflection later on.
But we're also going to explore a concept called adaptive denial. And I find this fascinating because adaptive denial goes against every instinct you might have as a human being to force a friend or a patient to just face reality.
We will spend a lot of time on adaptive denial because it is an absolute masterclass in neurological triage.
And finally, in our 80-20 breakdown, we have the must-know ethical and professional principles.
Yes, as a nurse, you have a critical mandate to establish a psychologically safe environment. You must have cultural competence in mourning rituals.
But perhaps the most difficult professional principle of all is the ongoing self-awareness regarding your own unresolved grief.
That's huge. You cannot act as a navigational beacon for a patient through their muddy waters if your own ship is sinking.
Now, I have to jump in here with a question that I think a lot of students or even seasoned professionals might be thinking.
Sure, what is it?
If I'm studying for a psychiatric exam or prepping for a clinical rotation, isn't grief just about death? When we look at the clinical frameworks for grief, the section on what actually constitutes a loss is massive. Why is it so broad? Are we like over-pathologizing everyday sadness?
That is the most common misconception in clinical practice, and honestly, it's one that will absolutely fail you on an exam.
And fail your patients in the real world.
Exactly. Grief is not exclusively tethered to the morgue. As a nurse, you're going to encounter profound, world-shattering grief in the amputation of a diabetic foot.
Wow, okay.
You will see it in a patient who just finalized a brutal divorce. You'll see it in the loss of a career due to a new multiple sclerosis diagnosis.
So it's about life-altering changes, not just death.
Even changes within a treatment setting, like a patient being transferred out of an ICU where they finally felt safe.
So if you only look for the symptoms of grief when someone flatlines,
you are going to completely miss the patient in room 4 sobbing uncontrollably over their new reality.
that is a massive paradigm shift. This realization that loss is literally everywhere in a hospital setting naturally leads us into diagnosing exactly what constitutes a loss.
Right. And to do that, psychiatric frameworks often utilize a structure that anyone who has taken a basic psychology or nursing class will recognize.
Maslow's hierarchy of human needs.
Exactly. But before we apply Maslow's pyramid to this, we need to clearly define our terms. Precision of language matters immensely in psychiatric nursing.
Because we tend to use words interchangeably in everyday conversation, right?
We do, but clinically they mean very different things. Let's separate them. First is grief. Clinically, grief refers exclusively to the subjective emotions and affect. It is the internal state. It's what the person feels inside. The anger, the sadness, the despair.
Right, it's the internal storm. It's the invisible weather system inside their head.
That's a great way to put it. Then we have grieving, which is also frequently documented as bereavement.
How is that different?
This is the process. It's the journey over time by which a person experiences that internal storm. It's not just the content of what they think and feel, but the mechanics of how they process it over weeks, months, or years.
And then mourning is the outward expression.
Yes. This is what the rest of the world actually sees, the rituals.
It's like having a wake or sitting Shiva, holding religious ceremony.
Wearing black, arranging funerals. Mourning is the cultural vehicle designed to carry the internal grief process into the community space.
And finally, we have anticipatory grieving.
This is when people facing an imminent, inevitable loss begin to grapple with the psychological reality of it in the near future.
Like a family moving a parent into hospice care, for example.
Yeah. Exactly. They are starting the immense neurological work of grieving before the biological event of death actually happens.
So keeping those exact definitions in mind, the internal grief, the ongoing process of bereavement, the external mourning, and the anticipatory dread. Let's talk about what is actually being lost to trigger all of this.
Right, going back to Maslow's hierarchy of needs.
How does a motivation theory explain loss?
Well, Maslow argued that a hierarchy of fundamental needs motivates every single human action. You start at the base with physical survival and move up to self-actualization.
So if any of those are threatened.
Right. When any of these core human needs are taken away, threatened, or permanently unmet, the human system experiences a profound loss. Let's start at the very bottom, the foundational bedrock, physiological loss.
This would be the physical body itself, I imagine.
Correct. This includes things like the amputation of a limb, a mastectomy, a hysterectomy, or the loss of basic mobility due to a spinal cord injury.
So the body is literally mourning its own altered architecture.
You will see patients grieve a lost limb with the exact same intensity they might grieve a lost spouse, because their fundamental physiological wholeness has been severed.
Moving up one level on the pyramid, we have safety loss. And this is fascinating because it's not just about a physical injury.
No, it's about the environment. This is the loss of a safe, predictable world. It is glaringly evident in survivors of domestic violence or child abuse.
Because a person's home, biologically and psychologically, is supposed to be a safe haven.
Exactly. When that trust is violated by someone they love, it's a profound, shattering loss of safety.
And it extends far beyond the home into public violence, doesn't it?
Think about the aftermath of a school shooting or violence at a place of worship. The physical injuries are one thing, but the entire community is plunged into a grieving process because their collective safety loss is absolute.
The world is just no longer predictable.
Exactly.
Next up the pyramid is the loss of security and a sense of belonging.
This is where the traditional concept of death usually comes in, as it violently severs the need to love and be loved.
But it also heavily includes divorce, chronic illness, and surprisingly, even birth or marriage.
Yes, because whenever a family dynamic shifts, even for a joyous reason like a new baby, the old roles within that family die.
Oh, I see. The exclusive dynamic a couple shared is lost and replaced.
Right. A teenager might grieve the loss of their parents' undivided attention. The human brain recognizes the loss of the familiar dynamic and initiates a grieving process to adapt.
Then we reach the loss of self-esteem. This is incredibly common, but rarely validated, I feel like.
It's extremely common. Any change in how a person is valued at work, in their relationships, or crucially by themselves, threatens their self-esteem.
So it can be an actual demotion or just their internal perception of failure.
Job loss, sudden retirement, or failing out of a nursing program fit perfectly here.
Because society heavily links our identities to our productivity.
Right. When you strip away the job title, the person grieves the death of their societal worth. And finally, at the very pinnacle of the pyramid, we have loss related to self-actualization.
So this is an internal or external crisis that permanently blocks a person from reaching their perceived full potential.
The classic example is someone who spent their whole life dreaming of going to college, writing books, and traveling the world.
But due to severe chronic illness or financial ruin,
they reach a point where it becomes mathematically evident those plans will never ever materialize. Or someone who desperately wanted to have children but faces irreversible infertility.
That loss of a deeply held dream requires a grieving process, just as grueling, just as real, and just as physiologically taxing as losing a tangible physical object.
Absolutely.
I like to explain Maslow's hierarchy to students using the analogy of a Jenga tower.
Oh, I like that.
Yeah, that self-actualization block, your dreams, your potential, your creative pursuits, is resting precariously at the very top.
Right.
If you violently pull out a fundamental block down at the bottom, like physiological health or a basic sense of physical safety, that self-actualization block completely destabilizes and crashes to the floor.
You cannot realistically worry about writing the great American novel or finding spiritual enlightenment when you've just lost your mobility or your home.
Exactly. The whole structural integrity of the human psyche shakes.
That Jenga analogy is perfect for clinical practice. The fulfillment of human needs requires constant dynamic movement and balance throughout all these levels. When a severe loss occurs, it completely obliterates that dynamic balance.
So once we understand exactly what is lost, we've identified the specific Jenga block that was violently pulled out, we must understand the underlying mechanics of how the human mind actually processes that sudden structural disruption.
Right, the pathophysiology.
What is the core neurological problem of grieving?
The core problem, biologically and psychologically, is the catastrophic disruption of homeostasis.
Okay, tell us about that.
If we look at crisis theory, specifically the foundational work of Aguilera and Messick, we see that a significant loss creates a profound state of internal disequilibrium.
Which the brain absolutely hates.
All right. It despises it. The human system, the nervous system, the endocrine system, the psyche despises unpredictability. It is desperately, aggressively trying to return to a state of balance. It wants homeostasis.
And to understand how people desperately try to regain that balance, psychiatric literature walks us through 4 major blueprints. These are the classic theories of grieving.
Yes.
I think anyone who has ever watched a medical drama on television has heard of the first one.
Elizabeth Kübler-Ross's stages of grieving,
Right.
originally developed in the late 1960s through her direct clinical observations of terminally ill oncology patients, it essentially became the cultural prototype for understanding all grief.
And it outlines 5 distinct stages, right?
Yes. Denial, which is the immediate neurological shock and disbelief. Anger, which can be entirely irrational and directed at anyone in the room.
Bargaining is next, I believe.
Right, bargaining, which is a fascinating psychological attempt to negotiate with God, fate, or doctors for more time. Then depression, when the acute, crushing awareness of the reality sets in.
And finally, acceptance.
Acceptance, which is finally coming to terms with the permanence of the loss.
It is easily the most famous framework, but clinical practice absolutely does not stop there. The literature brings in Bowlby's phases of grieving, which is deeply rooted in attachment theory.
Yes, and we need to explore the why behind Bowlby's theory because it's rooted in evolutionary biology.
Like pack animal survival instincts.
Precisely. Bowlby was a psychoanalyst who proposed that humans instinctively, biologically attain and retain affectional bonds for survival. We are pack animals.
So when a bond breaks, the brain panics.
When a primary survival bond is threatened or permanently broken, the biological response is intense panic, anxiety, protest, and anger. The brain literally thinks it is going to die without the pack.
Wow. And he had 4 phases.
Bowlby outlined 4 phases. First, numbness and denying the loss to buffer the shock. Second, emotionally yearning and actively protesting the permanence of the loss.
Then what?
Third, experiencing profound cognitive disorganization and emotional despair as the brain realizes the bond is truly gone. And finally, reorganizing and reintegrating the sense of self without that bond.
Okay, then we have George Engel's clinical model.
Engel approached it slightly differently, describing 5 stages heavily focused on the external mechanisms. First, the initial shock and disbelief. Second, developing awareness, where the dam breaks and crying, intense frustration, and anger emerge.
And his 3rd stage is really unique, right?
Third is restitution, which Engel uniquely pointed out is heavily focused on the participation in the formal rituals of mourning, the funerals, the gatherings.
Interesting. Then resolution and recovery.
Fourth is resolution, where the individual becomes deeply preoccupied with the loss and may intensely idealize the lost person, forgetting all their flaws. And fifth is recovery, where the obsessive preoccupation finally ends and life goes on, encompassing the loss rather than being defined by it.
And the 4th major blueprint we use is from Horowitz.
Horowitz divides normal cognitive grief into 4 stages of loss and adaptation, looking closely at how the brain manages the intrusive thoughts.
What are those stages?
First is outcry, the raw, immediate realization, which can manifest as outward screaming or a terrifying stoic suppression. Second is denial and intrusion, where people violently bounce back and forth between completely forgetting the loss for a moment and then being totally immersed and paralyzed by it.
It sounds exhausting.
It is. Third is working through, where the intense whiplash bouncing lessens. And finally, completion, where life feels relatively normal again, though fundamentally altered.
Now, wait a minute. I have to interrupt here because looking at these 4 models side by side, denial, anger, bargaining, shock, awareness, restitution, outcry, intrusion, these sound like neat, orderly administrative checklists. Does human emotion really work like a staircase? Do you, check off anger on a Tuesday and then happily skip up to bargaining on a Wednesday? Because that feels incredibly unrealistic and sterile.
I'm so glad you brought that up because what's fascinating here, and what is a critical safety issue for nurses, is that modern psychiatric practice includes a massive, explicit warning about this exact assumption.
Okay, tell me more.
It is a concept mastery alert. It states unequivocally to every clinician, there is no right way to grieve, and there is absolutely no orderly progression through easily identifiable stages.
So it's not a staircase.
Not even close. It is a messy, chaotic, dynamic process. Individuals may violently move back and forth between stages multiple times a day.
Oh, wow.
They might spend 5 years in one phase or pass through another phase so quickly it isn't even recognized by their therapist.
So if a nurse walks into a room expecting a patient to follow a neat textbook checklist,
they are going to severely misinterpret the patient's behavior, label them as non-compliant or abnormal, and completely fail to provide the correct therapeutic support.
To combat that staircase myth, psychiatric frameworks introduce the concept of the work of grieving.
Yeah.
We see Rando's 6 R's, recognize the loss, react to the separation, recollect and re-experience the deceased, relinquish old attachments, readjust to the new world, and reinvest emotional energy.
Yes.
And we see Worden's tasks, which include accepting reality and actively working through physical and emotional pain. Clinicians literally refer to this as grief work. Why is that specific word chosen?
The reason it is called grief work is because it demands immense measurable physiological and mental energy. Grief is not passive.
It's an active process.
It is an active metabolic and psychological expenditure. You do not just sit in a chair and let the magical passage of time heal you. The brain has to actively process the pain, rewire its expectations, adjust to a vastly changed environment, and find a psychological way to relocate the deceased in your life.
So it's burning energy.
It burns calories, it causes deep REM sleep deprivation. It is utterly exhausting work.
And because the physiological and mental work of grief is so incredibly taxing, certain individuals are at extreme, life-threatening risk if their system is already vulnerable.
Very true.
Or, and this is crucial, if their grief is completely invisible to the outside world. This brings us to a massive, profoundly important section of our clinical deep dive, identifying the risk factors for disenfranchised grief and complicated grieving.
Let's start with disenfranchised grief. These are the hidden mourners of society.
Hidden mourners. I like that phrasing.
This is grief over a profound loss that cannot be acknowledged openly, mourned publicly, or supported socially.
So the usual community supports that facilitate the healing process.
The casseroles, the time off work, the sympathetic cards, they're just entirely absent. The person is carrying the full weight of the trauma completely alone.
Clinical data breaks down several specific circumstances that cause this disenfranchisement. The first category is relationships that society perceives to have no legitimacy.
Right. In our culture, legally sanctioned, kin-based relationships get all the attention and sympathy. But what if the profound attachment wasn't publicly recognized?
Like what?
Consider cohabitation without a legal marriage. Consider the immense grief following the end of an extramarital affair where the bereaved must hide their devastation from their spouse.
That's a lot to process in secret.
Historically, and still in many communities, consider same-sex relationships that had to be kept secret. The biological attachment was real, the neurological trauma of the loss is real, but the person cannot mourn publicly without facing severe social stigma, firing from their job, or public exposure.
Then there's the category of unrecognized losses. These are losses that society gaslights the bereaved into thinking aren't big enough to warrant a grieving period.
These are incredibly common. Examples include prenatal death, early miscarriages, abortion, relinquishing a child for adoption, or the death of a beloved pet.
And non-death losses too, right?
It also includes severe non-death losses like a sudden job termination or divorce. The bereaved is experiencing intense, legitimate physiological grief, but the world around them perceives the loss as minor or entirely voluntary.
The implicit societal message is, you should be over this by now.
Exactly.
And sometimes the loss itself is recognized as tragic, but the griever is not recognized as capable of mourning.
This is an important one. Children and older adults frequently fall into this dangerous trap. Well-meaning adults assume young children don't truly comprehend the permanence of death.
So the child's behavioral grief is minimized or labeled as acting out.
Conversely, society often assumes older adults, especially those in nursing homes, should be used to death by now because they've seen so much of it, completely invalidating their acute pain.
There's also the category of stigmatized losses. For instance, the death of an incarcerated family member, death by a drug overdose, or death by execution.
The profound social stigma attached to the way the person died prevents the family from receiving the normal outpouring of community support. People don't know what to say, so they say nothing, leaving the family isolated.
And here's a crucial high-yield group for our nursing listeners. Healthcare workers.
Absolutely. Nurses who work in organ donation, oncology, or intensive care units form intense, empathetic bonds with their patients. They witness constant, relentless loss.
Yet, there is seldom a socially ordained place, time, or administrative protocol for them to grieve.
They are expected to bag the body, wash their hands, and cheerfully introduce themselves to the next patient in the bed. This disenfranchised grief is a primary driver of nursing burnout.
The literature specifically highlights the COVID-19 pandemic as a mass casualty event of disenfranchised grief for healthcare workers.
Yes, it accelerated this phenomenon globally. Healthcare workers were dealing with unprecedented, massive death tolls, serving as the only physical comfort for dying patients due to isolation protocols.
all while being physically separated from their own families and support systems to prevent infection.
The cumulative unprocessed grief was staggering.
But the clinical research also mentions a fascinating evidence-based intervention to combat this. Death cafes. What are those?
Death cafes are informal, pop-up forums designed specifically for discussing death, usually held in a relaxed environment over tea and cake.
So it's not a clinical setting at all.
No. The goal is to provide that missing, socially sanctioned space to process mortality and grief without the clinical sterility of a hospital boardroom. Extending these types of structured but informal debriefings into healthcare settings is heavily proposed by researchers as a way to combat the specific disenfranchised grief that destroys nursing careers.
So that is disenfranchised grief, the hidden, unsupported grief. But what about complicated grieving? When we assess a patient who is most vulnerable to their grief process derailing, becoming prolonged, dangerous, and biologically maladaptive.
As a psychiatric nurse, you are assessing for specific pre-existing vulnerabilities. People with chronically low self-esteem, deep-seated mistrust of others, previous psychiatric disorders, or a history of suicidal ideation are at incredibly high risk.
So past trauma is a huge indicator.
If a patient has a documented history of major depressive disorder, the trauma of grief can instantly precipitate a severe, new depressive episode.
But the assessment goes deeper than just their psych history. It gets very specific about how the nature of the relationship itself, their specific attachment style to the deceased, dictates the severity of the complication.
Yes, attachment theory is vital here. We unpack 3 highly dangerous attachment styles. First, the ambivalent attachment.
What does that look like?
This is when the feelings toward the lost person or entity were extremely unclear or mixed. Consider a person who is deeply uncertain about having an abortion but felt intensely pressured by a partner, or someone whose abusive parent dies.
The cocktail of relief mixed with profound sadness makes the cognitive processing of the grief incredibly complex and prone to stalling.
Second is the dependent attachment.
This one sounds like a massive red flag.
It is a massive red flag. This is when one partner relies entirely, completely on the other for their basic needs, financial, emotional, or physical.
So when they die.
When that caretaker partner dies, the surviving individual doesn't just lose a loved one, their entire mechanism for survival vanishes overnight. The grief is compounded by sheer existential terror.
And third is the insecure attachment, which is usually rooted in childhood fear, neglect, abuse, or control.
The healthy neurological coping mechanisms for loss were never properly formed during brain development, so the adult system is easily, catastrophically overwhelmed by a new loss.
We must also assess for environmental trauma. Sudden, unexpected deaths, multiple simultaneous deaths, suicide, murder, natural disasters, or community violence.
These events violently shatter the foundational safety block in Maslow's hierarchy in an instant, making prolonged, complicated PTSD-laced grief much more likely.
And the research brings up the COVID-19 pandemic again here, but this time specifically regarding the ICU visitation restrictions.
This is a highly testable, modern clinical reality that nurses must understand. Hard evidence shows that strict visitation restrictions, keeping family away from dying patients in the hospital, limiting human touch, forcing people to say goodbye over an iPad, caused a massive, statistically significant spike in prolonged, complicated grief among the bereaved.
Because the normal mourning rituals were blocked.
The normal, deeply ingrained human rituals of mourning and comforting the dying were forcefully blocked by institutional policy.
Knowing these risk factors is basically your radar. It tells the nurse exactly who to watch closely.
Exactly.
If you have a highly dependent patient with a history of depression whose spouse just died suddenly in a restricted ICU, every single clinical alarm bell should be ringing in your head. But what exactly are we watching for? When the alarm rings, what do we look at?
That brings us to the expected clinical findings across the 5 dimensions of grieving.
All right, break that down for us.
To assess a grieving patient properly, safely, and comprehensively, you must look at the holistic patient. You cannot just walk in, ask if they feel sad, document patient crying, and walk out.
Right.
You must evaluate the human response across 5 interconnected dimensions: cognitive, emotional, spiritual, behavioral, and physiological.
Let's break those down, starting with the cognitive dimension. What is actually happening in the patient's thought process? What is the brain doing?
The cognitive dimension involves the shattering of fundamental beliefs. The sudden loss disrupts the patient's basic neurological assumptions about life's meaning, justice, and fairness.
So they're searching for logic.
You will hear them questioning out loud, trying to force logic onto a chaotic event. Why did this happen? He ate perfectly. He ran marathons. He took such good care of himself. They are desperately searching the data for a reason that makes sense.
They also utilize cognitive mechanisms to keep the lost one present.
Yeah.
Right, like a buffering system.
Yes, frequently through internal dialogues, you will find patients silently asking the deceased for advice in their head or speaking to them as if they are in the room.
And that's not psychosis.
This isn't psychosis, it's a cognitive buffer. It helps soften the immediate crushing blow of the reality while the brain slowly processes the new data.
Then there's the emotional dimension. Obviously, profound sadness is present, but clinical data points out that anger and intense anxiety are actually predominant here. Why anger?
Because anger is a much safer, more powerful emotion than helpless despair. Anger gives the illusion of control. You will see massive resentment directed toward the deceased for leaving, toward the doctors for failing, or toward family members for not doing enough.
Is there guilt too?
There is also crippling guilt over things unsaid or actions not taken. Emotionally, the patient vacillates wildly. A patient might be totally calm and lucid 1 second and then consumed by a full-blown panic attack the next.
And what about reverting to childhood behaviors?
Furthermore, the bereaved often revert to deeply ingrained childhood behaviors, crying out and acting similar to a terrified child who is lost in a grocery store.
They are emotionally, instinctually searching for the parent or the lost loved one to come save them.
Exactly. It's a primal reflex. They might interpret a faint smell, like a specific cologne, or a random sound, like a certain phone ringtone, as a definitive sign of the deceased's presence.
Which gives them that brief hope.
This sparks a brief euphoric rush of hope, which is immediately followed by crashing, devastating despair when the reality resets.
Next is the spiritual dimension, which can be the trickiest for nurses to navigate.
During a profound loss, a person may be most comforted or entirely devastated in this specific dimension. You will frequently see deep spiritual suffering, absolute furious anger at God or the clergy.
A profound sense of cosmic abandonment.
How could a loving God let my child die? Or, conversely, they might suddenly find profound, unbreakable peace in the rigid belief of an afterlife.
And the nurse's beliefs don't matter here.
Regardless of the nurse's own beliefs, ministering to this spiritual suffering or facilitating this spiritual comfort is an essential, mandatory aspect of holistic nursing care.
Then we have the behavioral dimension. This is what the nurse can physically observe and chart.
Behaviorally, you might see a patient functioning entirely automatically. They are staring blankly, answering questions in a monotone voice, completely numb to reality.
And the opposite of that.
On the other end of the spectrum, you will see tearful sobbing, extreme physical restlessness, pacing the halls, and searching behaviors. They might obsessively seek out places associated with the deceased or actively, aggressively avoid them.
And we must highlight a major clinical warning here regarding maladaptive behavioral responses.
Yes. This is where you see severe drug or alcohol misuse as the patient attempts to chemically numb the emotional despair.
And the extreme end.
At the absolute extreme end of the behavioral spectrum, you will see suicidal or homicidal attempts if the patient's system determines it cannot survive moving through the process safely.
And finally, the physiological dimension. I want to spend time here because this proves that grief is not just in their head. This is where grief physically attacks the body. What is the cascade?
Grieving patients will present to the clinic with intractable insomnia, severe tension headaches, completely impaired appetite, rapid weight loss, profound lack of energy, cardiac palpitations, and gastrointestinal indigestion.
It's measurable. It's lab values and vital signs.
Highly measurable. The acute stress of grief causes a massive, prolonged increase in adrenocortical activity. The adrenal glands are pumping out cortisol as if the patient is being constantly chased by a predator.
Wow.
You see elevated levels of serum prolactin and growth hormone. This chronic flood of stress hormones causes severe immune system impairment. Grieving widows frequently catch pneumonia or severe infections shortly after the funeral.
And what about the heart?
It also significantly increases the mortality rate from cardiovascular disease, often referred to as Takotsubo cardiomyopathy, or broken heart syndrome, where the heart muscle is literally stunned by the adrenaline rush. Grief is a severe physiological stressor.
To really cement these 5 dimensions in our minds, let's look at a poignant clinical case vignette often used in psychiatric training about a couple, M and J.
Okay, let's break it down.
M loses J to multiple myeloma. Let's analyze M's specific journey through these dimensions.
When Jay was first diagnosed with the terminal cancer, M stated out loud, "It's a mistake, but I know it isn't." That captures the cognitive struggle perfectly. The brain is deploying denial as a shield while simultaneously acknowledging the terrifying reality underneath.
M also noted a distinct shift in how they thought about their social circle, realizing some lifelong friends completely disappeared when the illness got bad. That shattered their cognitive assumptions about loyalty and friendship.
And then, shortly after the funeral, M describes being in a completely mundane setting, grocery shopping, and feeling the physical pain of grief hit so hard they wanted to scream out loud, "Doesn't anybody know that I have just lost my loving partner?"
That is the classic emotional outcry phase Horowitz described.
Yes, the sudden, overwhelming panic attack in the cereal aisle. And look at the behavioral and physiological findings M reports to the clinician. Feeling physically wired with electricity due to the constant adrenaline, going through the daily motions feeling totally numb, and experiencing uncontrollable crying spells that lasted for 6 solid months.
M also expressed intense anger that they hadn't forced Jay to go to the primary provider a year sooner.
But the clinical vignette ends nearly a decade later, in the phase of reorganization. 9 years after Jay's death, M reflects on the grief process and describes it as a profound search for meaning in life, stating they are now content, confident, and find that the horrific experience ultimately led to massive personal growth, even though the happy memories and the twinges of missing Jay remain.
That represents the ultimate spiritual and cognitive resolution. They successfully integrated the profound loss into their new identity.
But notice the timeline. The journey took almost a decade, and it involved intense, dangerous physiological and emotional turbulence. It was not a neat staircase.
Recognizing all these complex findings, the electricity in the veins, the numbness, the anger in the grocery store, requires a highly targeted, structured nursing assessment. The nurse can't just guess what's going wrong or rely on a generic questionnaire.
No, they can't.
This brings us to the priority nursing assessment.
When you walk into the room, you rely on Aguilera and Messick's crisis theory framework. To help the patient restore their shattered equilibrium, the nurse must assess 3 critical interconnected components:
Which are?
perception of the loss, adequate support, and adequate coping behaviors.
Let's break those down. First, perception of the loss. What does this event actually mean to the client?
You have to ask them directly. You absolutely cannot assume. Let's use a powerful, highly testable clinical example: a patient who just had an abortion. To one patient, that loss might mean profound relief, the preservation of their bodily autonomy and safety. To another patient in the exact same demographic, it might mean devastating trauma, guilt, and the loss of a deeply desired child.
So if you, the nurse, assume their perception based on your own political, religious, or personal biases,
You will destroy the therapeutic relationship in 3 seconds flat.
the nurse needs to sit down and ask broad, open-ended questions. What are you thinking and feeling about the loss? How do you see this affecting your life moving forward?
Second, adequate support. Who is physically and emotionally there for them? The nurse must assess if the patient has a network that can meet their needs. Do they have family, a church, friends?
And if they are completely isolated, the nurse must actively help identify community support groups or online resources. You cannot discharge a grieving patient into a total vacuum.
Third, adequate coping behaviors. How is their baseline functioning impaired?
This is where your observational skills are paramount.
Are they eating the food on their tray? Are they sleeping through the night or pacing the halls at 3 a.m.? You must also ask how they have dealt with severe loss previously. Are they relying on healthy coping mechanisms, or are they exhibiting signs of substance abuse, extreme denial, or self-harm?
So practically speaking, what does this all mean for the nurse walking into the room with the clipboard?
Yeah.
You've got this framework: perception, support, coping. What is the immediate priority?
The overarching non-negotiable priority is always assessing for physical safety first. You are screening for acute suicide risk and dangerous physiological deterioration.
But from a purely therapeutic standpoint,
Assessing their perception of the event is the key that unlocks everything else. If you do not understand what the loss fundamentally means to their identity, you cannot possibly help them cope with it.
okay, let's say we've assessed the patient. We've verified they are safe from immediate physical harm, but they are deep in the muddy waters of the grieving process. What are the actual nursing interventions? How do we proactively care for the grieving client without making it worse?
It begins with the foundation of creating a psychologically safe environment. In psychiatric nursing, we emphasize attentive presence.
This isn't just being in the room, is it?
No, it's a specific physical posture. It means open body language arms, uncrossed, sitting down at eye level, facing the client, and maintaining moderate, non-threatening eye contact.
And keeping your mouth shut sometimes.
It means absolutely refraining from judging their emotional state or offering specific, unsolicited life advice. Sometimes you literally just sit in the silence with them.
And then the clinical frameworks introduce a concept that I think might confuse a lot of people, or at least it goes against every dramatic intervention we see on medical TV shows. It's called promoting adaptive denial. Explain this mechanism. What is adaptive denial?
Adaptive denial is one of the most crucial concepts in grief care. It is the neurological process where a client gradually, subconsciously adjusts to the devastating reality of the loss in tiny, manageable increments.
Because taking it all in at once is too much.
Taking in the entire magnitude of the loss all at once is psychologically and physiologically overwhelming. The brain would short circuit. So the mind deploys denial to cushion the blow. It rations out the trauma.
You hear this when a patient says, I can't believe this has happened. The lab made a mistake. He's going to wake up.
Exactly. And the most important nursing intervention here is to allow this adaptive denial to function. You do not forcefully shatter their denial.
So you don't grab their hand, look them in the eye and say, you need to face reality right now. Your husband is dead.
No. That is cruel and neurologically dangerous. Instead, you gently guide them toward reality by asking reflective questions that link their physical feelings to their hidden emotions, allowing them to process the horror bite by bite.
We also have crucial physical interventions because, as we established, grief is a massive physical stressor.
The nurse must actively promote rest, gentle exercise, and hydration. A classic, highly testable intervention is offering food without pressuring the patient to eat.
Right, because forcing a patient to eat or lecturing them about nutrition while they are sobbing causes intense anxiety.
You simply make the nourishment easily available. You quietly bring the tray, leave it within reach, and say, I brought some soup if you feel up to it.
The clinical literature also highlights a major evidence-based practice study regarding complicated grief interventions.
Yes. A large-scale, randomized controlled trial focused on cognitive behavioral grief therapy, or CBGT. The data conclusively proved that participating in a structured CBGT group resulted in a substantially greater decrease in severe complicated grief symptoms compared to basic psychoeducational interventions or standard talk therapy.
So the takeaway intervention for the bedside nurse is recognizing when standard grief has morphed into complicated grief and then actively referring those patients to specialized CBGT therapists.
Precisely. You do not try to manage severe, prolonged, complicated grief on a med-surg unit with basic active listening. It won't work. You escalate to evidence-based therapeutic interventions.
We also have to individualize care through cultural and ritual interventions, which goes back to Engel's focus on mourning.
The nurse should always ask the family what they need in the moment. Would you like me to call a chaplain to pray? Would you like me to stay with the body while you make phone calls? You must encourage the patient to use whatever rituals are meaningful to their specific culture, rather than assuming you know what that is based on their chart.
The literature gives incredible examples of large-scale national rituals that facilitated massive public healing.
Like the AIDS quilt.
Yes, which allowed thousands to physically memorialize victims in a society that was largely shunning them. The profound, silent planting of the flag at ground zero while exhausted recovery workers maintained an attentive presence. And the 168 empty chairs placed at the memorial in Oklahoma City.
Those public physical memorials play a massive psychological role in the healing process because they provide explicit social sanction and community support for the grief. They are the ultimate antidote to disenfranchised grief. They tell the mourner, your loss is real, it is massive, and we see you.
Well, we desperately want to facilitate that beautiful natural healing process as nurses. We must remain hypervigilant for when the process derails into a life-threatening psychiatric emergency. Let's outline the safety red flags. What requires an emergency response?
Immediate, acute interventions are required for 4 specific scenarios. Number 1, and the most critical, suicidal ideation or homicidal gestures. If a grieving patient shows profound despair combined with a formulated plan, or if they have risk factors like a past psychiatric history, instituting strict suicide precautions is the absolute priority. Do not pass go.
Number 2, clinical depression, but specifically a certain depth of depression.
Right. We expect sadness. But we're looking for clinical depression that renders the patient entirely unable to perform basic ADLs. If the grief is so heavy that they cannot physically get out of bed, bathe themselves, or safely navigate their home, they require immediate psychiatric and medical intervention.
Number 3, severe physiological deterioration.
We discussed the immune system crash and the hyperadrenocortical activity earlier. If a patient is experiencing dramatic, rapid weight loss or an acute immune failure due to the biological stress of grief, medical intervention is urgently required to stabilize the body before the mind can heal.
And finally, number 4, maladaptive thought patterns.
The literature specifies dangerous cognitive loops. Relentless rumination, catastrophizing, and agonizing over doing the right thing to the complete exclusion of any basic problem solving. It also includes totally inadequate emotional regulation, where the patient ignores all regular daily routines and focuses exclusively, obsessively on negative emotions without ever taking a neurological break.
If we connect this to the broader psychiatric picture, the clinical guidelines explicitly note that grief is a primary catalyst that can precipitate major depressive disorder in clients with a history of the disease.
It is a massive, highly predictable trigger. When you are caring for these patients, you're not just monitoring their grief process, you are aggressively monitoring the stability of their underlying psychiatric baseline.
Handling these red flags and facilitating normal grief requires elite, highly practiced communication skills. Knowing what to say is just as important as knowing what to avoid. The clinical training materials actually provide transcripts of clinical dialogue to show us exactly how this looks. Let's do a role-play analysis of one of these scenarios to see the mechanics in action.
Let's analyze the classic scenario with the patient who just learned she has aggressive breast cancer and needs a mastectomy in 2 days. The nurse walks into the room. The patient is quietly crying in the dark, and her dinner tray is completely untouched. The nurse opens with, "I wonder if you are upset about your upcoming surgery."
And the patient responds, eyes wide, "I'm not having surgery, I don't need it. The biopsy was flawed, that is the adaptive denial kicking in hard."
Yes, the neurological shield is up. Now, a novice nurse, or a nurse focused entirely on the surgical checklist, might argue with her. They might say, "The doctor explained this morning that you have cancer, you have to have the surgery to live." But the transcript shows the expert therapeutic approach. The expert nurse bypasses the medical debate and says, "I saw you crying and wonder what is upsetting you. I'm interested in how you are feeling tonight."
Notice what the nurse did there. They focused entirely on the observable behavior, the crying, and accepted the patient's denial without confirming or denying the surgery.
Exactly. The patient then deflects again, saying, "I'm just not hungry, I don't have an appetite at all, and honestly, I'm not clear about what the primary provider even said this morning," he mumbled.
The patient is dodging the terrifying emotional reality and focusing on the tangible physiological symptom, the lack of appetite, and blaming the doctor's communication.
So the expert nurse connects the two concepts gently. The nurse says, "I wonder if not wanting to eat may be related to what you are feeling inside. Are there other times in your life when you don't have an appetite and you feel upset about something?"
That right there is promoting adaptive denial. The nurse is gently, indirectly suggesting a connection between the physical symptom and the hidden emotional distress, without ever forcing the terrifying words cancer or mastectomy into the conversation before the patient is ready.
And if you look at the transcript, it works. The patient acknowledges the connection but still denies the immediate reality, saying, "Maybe, but I can't think of what I'd be upset about today." So the nurse gently pushes just 1 millimeter further. "You said you were unclear about what the primary provider said. I wonder if things didn't seem clear because it may have deeply upset you to hear what they had to say. And now tonight, you don't have an appetite."
The nurse is using the patient's own breadcrumbs to draw the map. And the patient finally breaks, takes a breath, and asks, "What did the primary provider actually say? Do you know?" They are finally demonstrating a neurological readiness to hear the reality again. The nurse guided them to the truth incrementally, without shattering their defenses.
That is absolute mastery of therapeutic communication. Other key evidence-based phrases the literature suggests include using simple, validating, non-judgmental statements like, "I want you to know I'm thinking of you," using the deceased's name naturally in conversation if it is culturally appropriate.
And utilizing the profound power of silent presence. Just sitting in the chair next to the bed indicates deep caring. Conversely, what should the nurse absolutely avoid saying?
Never, ever say, "You need to face reality." Do not judge their timeline. Do not give specific life advice like, "You should sell the house." And strictly avoid false reassurance like, "Everything will be okay," or "They are in a better place. It won't be okay. Their world just ended." Validate their unique, messy timeline instead.
As we transition into the final phase of our mentorship today, let's talk about NCLEX and board exam logic. How do testing boards evaluate this incredibly dense, nuanced material?
The boards test two main things: your prioritization of safety and your mastery of therapeutic communication. For priority action questions, if a scenario describes a grieving client demonstrating severe despair, hopelessness, and they have risk factors like a prior psychiatric history or a lack of support, the correct answer is always, unequivocally, to institute suicide precautions. Safety first, above all else.
What about questions asking for the best therapeutic response? I feel like these are always the trickiest.
The correct answer for therapeutic response will almost always be the option that validates the patient's unique timeline and utilizes reflection rather than offering a solution. For example, if a patient says they are disgusted with themselves for crying so much after 3 months, the best response is pure reflection. You're pretty upset with yourself, thinking you should feel differently by now. It doesn't judge, it doesn't fix. It simply opens the door for them to explore their own unrealistic expectations.
On tests, and honestly, on the floor in real life, young nurses often have a desperate urge to fix the patient's sadness. They want to pick the multiple-choice answer that cheers the patient up or offers a silver lining.
And the test makers know that. They prey on that instinct. The correct answer is rarely to fix the grief. It is to safely facilitate it. Furthermore, if a question describes a patient who has completely absent grief months after a horrific loss, or someone who is so overly immersed in the deceased possessions that they haven't eaten in days, that is a safety-based question, testing your ability to recognize complicated grief. You must follow up on those maladaptive behaviors immediately.
As we wrap up this clinical deep dive, the literature leaves us with an incredibly important, sobering outro regarding self-awareness for the psychiatric nurse.
To be trustworthy to your patients, to truly be a healer, you must conduct ruthless, ongoing self-examination. You have to look in the mirror and ask yourself, what are the unresolved losses in my own life? Am I currently grieving? Is the pain of my personal divorce or my own miscarriage subtly spilling over as I listen to my patient cry? If you are projecting your own unresolved loss onto the patient, you cannot maintain therapeutic boundaries. You become a liability.
So, to summarize our 80-20 clinical takeaways, know the physiological and psychological difference between normal, disenfranchised, and complicated grief. Assess for safety, first suicide risk, and physiological neglect like dehydration. Understand that grief is not a neat 5-step checklist, but a messy, dynamic, metabolic process. Use adaptive denial as a tool and employ open-ended reflection. And always, always check your own emotional baggage at the door before entering the room.
If you've absorbed this, you've significantly upgraded your clinical judgment today. You have the actual tools to navigate these muddy waters safely and bring your patients to the other side.
But before we let you go, I want to hand it over to my co-host for one final, provocative thought extrapolated from the clinical realities we covered today.
We spent a lot of time today talking about the disenfranchised grief of nurses, the hidden mourners working in organ donation, oncology, and the ICUs. We talked about how the pandemic severely restricted mourning rituals, spiking complicated grief and PTSD across the profession. If the entire architecture of our healthcare system implicitly relies on the endless emotional labor, the silent suffering, and the sheer resilience of these frontline nurses, yet offers no sanctioned time, no death cafes, and no space for them to mourn the relentless string of devastating losses they witness on a daily basis. What happens to the integrity of our medical system when the foundational Jenga block of the caregiver's own psychological safety is finally pulled out entirely?